You are welcome to my channel. Today I'll be addressing hypertensive emergency. By definition, hypertensive emergency means that there is a very high blood pressure, but not that the blood pressure is high alone. In addition to that, there are signs of end organ damage, requiring emergency intervention to lower the blood pressure. We should note this. We can't crash that blood pressure. In the first 1 hour, the blood pressure can be reduced by about 20%. For example, the patient has come in with 220/120 millimeters of mercury. Within the first 1 hour, we can reduce that to 180/100 millimeters of mercury. In the next 24 to 48 hours, we can have that same blood pressure reduced to about 130/140/80 to 90 millimeters of mercury. Also noteworthy is that not everyone with high blood pressure is qualified for the emergency treatment, perhaps because it is not hypertensive emergency. For example, if there is no end organ damage, even the BP is very high, there is no need to rush to treat. You are expected to use intravenous antihypertensive agents, but do that cautiously, please. Don't admit if this BP is high but it is asymptomatic. That is hypertensive urgency. Don't crash the BP. I've repeated this about 2 or 3 times now within 2 minutes. If you crash the BP, you may get stroke, transient ischemic attack, orthostatic hypotension, and falls, with the consequences of falling in that patient. In other words, you may be doing more harm than good. The patient might have come in with a stroke, when we crash it, he or she will go back with stroke. Symptoms of hypertensive emergency. Needless to say that the BP will be very high, but sometimes not as high as some will expect. Could be 170/110, or 180/110, or 220/120 millimeters of mercury. But it's going to be high. In addition to that, there will be chest pain. There might be features of myocardial infarction, known commonly as heart attack, dyspnea, headache, confusion, or agitation. There might be loss of visual acuity, fatigue or weakness, dysarthria, palpitation, vascular dementia, or seizures. But the physician will pick some signs of hypertensive emergency, like stroke, could be diagnosed here, subarachnoid hemorrhage, intracranial hemorrhage, left ventricular hypertrophy, heart failure, aortic aneurysm, or aortic dissection. Also, there could be features of pheochromocytoma, if pheochromocytoma crisis is what we have at hand. Features of coronary artery disease or delirium, severe preeclampsia in pregnant women or eclampsia, and of course, retinopathy with papilloedema. Other signs of hypertensive emergency will include microscopic hematuria, pulmonary edema, albuminuria, atrial fibrillation on EKG or ECG, depending on where you are in Europe or North America, hypertensive encephalopathy. What are the possible causes of hypertensive emergency? Most of the times is as a result of cold turkey stoppage of antihypertensive agents. Patient just decides on his or her own, I'm going to stop this. So medications are no longer taken. Then the BP is now up. Could be as a result of pregnancy, preeclampsia. I don't want her to start convulsing, which is eclampsia. Might be as a result of street drugs, particularly cocaine. Might be something as simple as decongestant, an over-the-counter medication. Might be as a result of anxiety, or medication like tacrolimus, or might be secondary to pain. Might be caused by myocardial infarction, particularly with ruptured plaque. Sometimes it could be iatrogenic because of endotracheal intubation. Might be because there's anemia and you've administered your erythropoietin and we're now dealing with side effects. Might be aortic dissection, cerebrovascular accident, or cyclosporine medication. We are going to carry out certain investigations here. First thing first, CT of the head with non-contrast, please. We will hook up the vital signs machine, and with that we'll be able to read the blood pressure, the heart rate, the oxygen saturation, and temperature. The ECG or EKG will reveal left ventricular hypertrophy present and any arrhythmia. The chest X-ray will show the pulmonary edema or the cardiomegaly. The ultrasound can reveal the aortic dissection, any problem with liver or the renal system. Reanalysis will show whether we're dealing with albuminuria or hematuria or not. And of course, toxicological screening will reveal if we are dealing with street drugs here, particularly cocaine and other drugs. Part of the investigations will include cardiac enzymes because we want to be sure if we have or we don't have myocardial infarction at hand. Electrolytes, blood urea nitrogen and creatinine to know how the kidney is doing, complete blood counts, APT, APTT, von Willebrand factor, and BT to show the clotting profile. Intervention. No doubt, I'm going to admit, and specifically into intensive care unit, but I will not be tired to keep repeating right here that we cannot crash that blood pressure. Nowhere. Acute rise in blood pressure will require acute intervention. Chronic rise in blood pressure will require slow intervention compared to acute rise in blood pressure. Still on intervention, the first 1 hour, the BP can be reduced by 20%, as said earlier, and between 24 to 48 hours to have come down to the level of 130 to 140 over 80 to 90 millimeters of mercury. Just don't crash the BP. Involve your cardiologist, please. There are many good medications that we can choose from when it comes to intravenous antihypertensives. Enalaprilat, phentolamine, or phenozbenzoamine if it is pheochromocytoma related. Labetalol, phenoldopa mesylate, clevidipine, nicardipine, hydralazine, nitroglycerin, esmolol, and nitroprusside should be the last choice. And someone is saying, why would nitroprusside be the last choice? Yes, I'm not so comfortable to use nitroprusside because nitroprusside, in the face of increased intracranial pressure or myocardial infarction, will cause more lactic acidosis. So you have to be careful in face of renal failure, liver failure, or pulmonary edema. It's better to avoid nitroprusside. Still on interventions, analgesics should be used if you suspect that it causes pain. You can use fentanyl here. Anti-anxiety medications if the cause is anxiety related. Diuretics, but hemodialysis would be appropriate if you're an intensive care unit. And lastly, still on intervention, return to order regular for oral antihypertensives after the acute case has been resolved. But don't use non-dihydropyridine calcium channel blocker here. In other words, keep off verapamil and diazepam. And with that, I've come to the end of this presentation as per hypertensive emergency. We should be sure that it is truly hypertensive emergency because the intervention is a bit different from hypertensive urgency. But when we put everything all together, in fact, the intervention is far apart of the resources. Using intensive care unit, of the amount of investigations, and of course, using intravenous antihypertensive agents will not be required in the face of hypertensive urgency, but all will be needed in the face of hypertensive emergency. You can see, making that determination with clinical signs and symptoms of end organ damage will save us and save the patient of time and money. Thanks for listening. Remember to subscribe. Remember to share this very presentation. I appreciate it.